Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 137. Hopefully all of you are staying safe with the resurgence of COVID-19, and hopefully there is a lot of good news on the way, and it is our expectation that several of us in the front lines of COVID-19, working diligently in the cardiac catheterization laboratories will be the preferred physicians getting one of the several available vaccines coming our way. Hopefully, till that time, we'll all stay safe, continue to do all the amazing work. I can attest to you that this morning, today is probably as busy a day at Mount Sinai Hospital. I noticed they already had 44 cases scheduled for today. Today's case is unusual. It's not your garden variety case which you find. This is a multi-layered DES in-stent restenosis and with the CTO. And the management of these cases is difficult. It is different. It's only up to a certain point you can squeeze another oversized balloon under high pressure or use a cutting balloon. I think in majority of these cases, the sensible therapy is going to be either a drug-coated balloon or even more relevant IVBT. So to take us through such an unusual case with not your garden variety management, we've assembled the world's best expert. It is Dr. Ron Waxman from Washington, D.C. Ron really doesn't need much introduction. Dr. Waxman, I am sure you recognize him as the course director of what I consider is possibly the world's best interventional live demonstration course, the CRT. His other title is a professor of medicine at Georgetown University Hospital and associate director of MedStar Cardiology. But without being overtly flattering to him, I can truly provide you my own individual assessment. You want to choose a single dedicated interventional meeting a year, go to his meeting, you will not be disappointed. Dr. Waxman will also take us through the specifics today of the need for IVBT, its precise logistics, which are quite different, the Novo system, and several other very specific aspects of this case. Samin, good morning. I believe there was some delay in getting access for this patient. And of course, I'll have you also individually chime in your introduction for Dr. Waxman.
Oh, of course. Yes, good morning to all and our CCC Live viewers, and more importantly today as a guest faculty, Dr. Waxman. And Dr. Waxman, welcome. You have been here 2 times in the past, but now with the Zoom, with the life-changing, and myself and Dr. Keeney welcome you. And this will be a new experience for us also, because we have invited faculty in person in the CCC Live, and first time we'll have a Zoom faculty, and we could not find a better person than you, and so appropriate for this particular case, who had a multiple stents and prior brachytherapy, and what to do with this case who has multiple stents and clearly has refused coronary artery bypass surgery many years ago. So Anu, you want to just say hello to Dr. Waxman and then we start.
Good morning, Ron.
Good morning. I'm honored. Thank you for the kind introduction. Obviously, a lot of exaggeration, but be happy to comment. And again, congratulations on your 137 cases on CCC Live.
Ron, absolutely no exaggeration about your terrific meeting. I was attending that for after a few years last year, and it was absolutely fantastic. Despite the meeting being so large, it has had a sense of personal involvement, and I heard that comment from many attendees. Ron, I'll start this right away as we get some initial shots of the right coronary artery. Straight away upfront, should most of the smaller institutions, should it not be their default strategy to refer such cases out?
Yeah, so obviously in-stent restenosis is considered to be a challenging from the therapy aspects because there is a very high recurrence rate no matter what you do. So we basically narrowed our options to the etiology. If this is an underexpanded stent, which is in many of the cases, then what you should do is just dilate this, and you don't have to do much more than that. But you really need to prove that this is an underexpanded stent situation or fracture stent. But if you do have a tissue, our options are another DES, which was in this case probably done multiple times without much help, drug-coated balloon, which again, there is a lot of controversy which one is better, drug-coated balloon versus another DES. And then you have the brachytherapy, and then you have CABG. So nobody wants to go to CABG, so let's put that aside and we'll try to avoid it. But I do think that, again, being biased, that brachytherapy is probably the most effective modality that is available right now. And not every center can have brachytherapy. I would encourage, if you have this situation, which is like this case, multiple recurrences, you tried it already a couple of times, send it to a center that does have brachytherapy.
So how many of such cases does MedStar Washington do?
So we do about 120 to 150 a year. We are considered to be a referral center. Obviously, New York does have it with Mount Sinai, but when you go from Philadelphia all the way to the Miami area, there is really nobody that does brachytherapy. So we're covering a very large area. And again, we are not getting the first or the second. We're usually getting more the third and the fourth ISR. So about 150 cases brachytherapy. I have to say that we have much more in-stent restenosis, but we don't rush to treat them first time with brachytherapy. We always give a first chance with a DES in the first time, another DES, and only if they fail the second time, that's where brachytherapy enters into the play.
Good old IVUS good enough for imaging, or OCT in selected cases?
So I think that no matter what, if you choose IVUS or OCT, they're both good. They actually help you to understand the mechanism. And I think that's, again, very critical. Sometimes you're not going to see any tissue. So if you do not see any tissue, then why bother with brachytherapy? That means that right now you basically have a mechanical problem, and that's probably would be better addressed with another stent or balloon with a stent, but there is no need for brachytherapy. But should you see a lot of tissue there as the main mechanism for restenosis or even neo-atherosclerosis, then I think brachytherapy should be the first modality.
Where would you use drug-coated balloons? Any specific areas where the two modalities fit?
So for those who still see late recurrences of bare metal stent restenosis, remember bare metal stents can restenose 10 years after the case, I think drug-coated balloon is very good position and probably will give you the best results. If you're looking into DES restenosis, you can always try the first time drug-coated balloon. And again, we do not have it in the US, but this is a global meeting. So in fairness, I have to say that it's fair to give a chance because you want to minimize the number of layers of stent that you are placing. Also, when we do brachytherapy, we never put another stent. We do balloon and brachytherapy. So it's a fair chance to do the first restenosis recurrences in areas that you do not have brachytherapy and you don't like to put another layer of stent, you can try drug-coated balloon. But if you try drug-coated balloon and it did fail, and it does fail, I know for DES, then again, another DES is an option, or then you have to think about heavily brachytherapy.
And Ron, we are dealing at the moment only with beta radiation, no? The Novo system. Can you tell us a little bit about the isotopes being used?
That is correct. So the beta cut system that was developed by Novost, so it's known either beta cut or Novost, It has a strontium yttrium 90 source. This source has a half-lifetime of 30 years. Now remember, we started it in 2000, so almost 20 years. So clearly we have another good 10 years to run with this source, which is a nice thing without changing anything. Then we'll have to change the source. The source is beta, so that means that it's radiate only at a depth of 5 millimeters from the center of the source, which is basically a safe, because anyone in the room, even for the patient, for the staff, for the personnel, there is really no exposure to the radiation. And even within the heart itself, following 5 millimeters from the center of the source, there is really not much radiation that is being detected. So it is a very safe application, and that's, I think, has to be explained to patients and to the staff. The other thing which is unique about the system, it is compatible with 7 French. 6 French, sometimes you can push it, but we prefer 7 French, so not kinking the catheter. The system itself has a transfer device. The transfer device hosts the train of seeds. There are basically 2 trains of seed, one of 40 millimeter length and one is 60 millimeter length. So if you have to cover an area of 40 millimeter, you would use the 60 millimeter. If you have to cover an area of 30 millimeter or below, you can cover that with 40 millimeter. You want to have about 5 millimeter edge space to cover the entire zone and to prevent any geographic miss. Now, what happens if you have a full metal jacket of 70 millimeter? In that case, you have to do 2 steps with some overlap, and you can use the 40 times 2 that will give you altogether almost an 80 millimeter. Or if you have 100 millimeter full metal jacket, you can use the 60 times 2. So you place the catheter distally, you wait about 5 to 6 minutes, that the dwell time right now. Just an anecdote, when we started in 2000, the dwell time was about 3.5 minutes, and then you do 2 steps. But I see
Ron,
that Samin is ready.
Yeah, exactly. I was going to tell you that. Samin,
I'll
take
stop
us
here.
through the
Let
case and the plans.
Okay, so let's go with slight delayed start with the access issue because of these are our the participants, myself, Dr. Keeney, Dr. Mehta is the moderator, and we have guest faculty with Dr. Ron Waxman. So this case is case number 137, 65-year-old male. He started having CAD about 15, 16 years ago, and had multiple vessels, multiple stents, more than 8, 9. All 3 vessels always have refused CABG. He had multiple CAD risk factors, but they are very well controlled on parameters of the blood pressure, lipids, A1C, and so. So he recently presented with again class 3 angina with high risk stress MPI for multivessel ischemia, and did have multivessel disease, and it was intervened with the LAD diagonal by Dr. Keeney about a month ago, and patient also is a clopidogrel non-responder. So usually we don't do it, but for some people, diabetic multiple stenosis, we do check for clopidogrel responsiveness, and this patient was placed on Pressagul for that purpose. And now presented, we're just going to share with you, LAD diagonal was done about a month ago and has a little residual circumflex LPL, but the case is the multi-layer DES ISR of the RCA. LV is preserved. As you can see, this particular case, there is a LPL disease, but this is the right coronary, which count because majority were done here, some cases outside. He probably has about 9 stents in the right coronary, and with the had a brachytherapy of the distal segment in the past, and then presented recently with the total occlusion. You can see very little filling, but large right coronary artery. And next picture, an ostial, not truly ostial, but few millimeter later, you have very thin origin, and then total occlusion of the this instant restenosis, where only 1 stent could be bare metal. We cannot account, but multiple layers of first and second generation DES has been placed in this right coronary artery. So that's where we are now, based on the, if we go back to our presentation. So in terms of this particular case, let me just go back here. So plan today, is now patient has a residual syntax score of 10. He had 22 before LED diagonal PCI. And this is planned today to do multi-layer with IVUS guided PCI with such a long occlusion that you probably will need atherectomy. And then, of course, IVUS or OCT. Initially planned was OCT, but patient creatinine baseline used to be 1.2, 1.3 maximum, but today is 1.5. So we probably will avoid OCT because of the dye use and maybe use the IVUS. Yeah, and patient also have a CI in the past, and the IVUS will use the IVUS. It's the same idea to see stent under expansion, and so use the IVUS. So appropriateness we always show. Two vessel disease with LPL, and this right coronary artery patient on multiple medical therapy. So it's appropriate. So with that note, we are ready to start the case. Let's go live, please, and we'll continue to have comments, expert comments by Dr. Waxman.
So
now this is the fielder.
7 French guide.
It's a 6 French because remember in this particular case we want to minimize the dye and therefore it's a 6 French guide. So we would have gone with a 6 French otherwise also, as Dr. Waxman pointed out, some cases where you need a guideliner and if you, to deliver the radiation seeds, you need a 7 French guideliner. 6 French is very tough, although we had done rare cases, but we had live case also one we did a few years ago. 6 French did not go, so needed 7 French. So in this particular case, reason to go to the smaller one is because of the creatinine issue. So this was the fielder and fine cross, and Anu is ready to escalate the wire to
Gaia 3.
Now with the Gaia 3, yeah.
Straight away, didn't take too long to move to the trusted wire, Anu.
Well, I must say that instant restenosis, even though you have kind of the guidelines by the silhouette of the stent, sometimes are very hard to cross because especially if you have an underexpanded stent, you can go through struts. So it's not necessarily a slam dunk CTO.
Right.
Actually, sometimes the ISR are more difficult than native. Because
Exactly.
of many times you go subintimal and you go wire start going behind the stent struts. And so in this case, this is the Gaia, and going to all the branches, at least that's good. Now, as you know, the Gaia has a new variety now, Gaia Next, which is a little stiffer tip and a little more...
It's...
Epicranial?
Yeah, 1 second, yeah. I'm into
Okay, I'm going
the
to
PDA.
epicranial.
Okay, I'm in the PDA.
Yeah.
And to change the rota wire.
Okay, let's get the rota wire, please.
Extra support or floppy?
Extra support, extra support.
Now
this one, so key, this is a fine cross going through, and see the guide support is a little not great, and it's not a case for AL. Yeah, so question is, should you have done the AL? But AL would have really dampened, very disease ostial. So we'll try to see if this can work it out with the guide position, but wire has gone distally, which is good. And even if there, it will be good enough. We start with a 1.25 bar.
No, I think 1.5.
1.5 bar.
We'll be here whole day.
Yeah.
So
Okay,
one
change the
question
rota wire.
about ablation. There is obviously multiple ways to do it. You can do laser, you can do rota, and you can just do simple balloon. I don't know if the data really support one versus the other.
Right.
And we moved mainly to do just HOBA, high pressure balloon, sometimes cutting balloon. But rota is very interesting approach. The only thing that I'm worried sometimes is distal debris to the distal branches. So from previous cases, how big is the run of vessels? Because that's, I think, would determine whether I would use rota or not, because if there is a very small runoff, then you're always concerned about sending debris downstream.
So Ron, for the sake of completion, any role of orbital?
I don't have much experience with orbital in instant restenosis.
I should have directed that to Samin. They probably have the world's biggest. Samin, any role of orbital here?
Yeah, so question is, with such a long ISR, I mean, clearly that, yes, first, let's talk about the balloon alone. I think the balloon alone will be a little more difficult to expand it. This case, if you want to do atherectomy, maybe the laser is a reasonable approach.
Well, laser also, I think, works excellent in the protected environment. It's a straight shot, and you can even go to the larger size.
Good. Yeah, and then this one such a long. So I would be our experience in this one would be majority using the atherectomy, and actually I'll show you the data also that overall for ISR the use of atherectomy by our NCDR is almost 16%. So while the native vessel we do 3 or 4% atherectomies, but for the ISR treatment much higher use of atherectomy in the United States. So clearly because of such a diffuse and long disease.
3 or 20 or 30. Okay.
30. Yeah. So this is, we had done now the rota extra support wire exchange over the fine cross and with a 1.5 bar. Now, if our fine cross would not have advanced, then we would have gone with a 1.25.
Don't make noise.
And you're going to use the Rota Pro. I can see it already there. So
yeah, so it's a Rota Pro 2. Yeah, Rota Pro 2, which has on the everything on the advancer, your Dynaglide and so, and has really made, to me, another engineering change that it gives little resistance. In the past, problem with the Rota Pro was, it just was going further and no resistance, and that's why many times burr entrapment happened. But they did engineers, I visited their plant, gave them a lot of advice, and made these changes. So it looks much better now, this Rota Pro 2. So
yeah, going back to using RA versus OA in these cases, I think mechanistic wise also, if you think about it, in ISR, rotational atherectomy works better compared to OA. OA is orbital, it just orbits around, compared to rotational atherectomy is a differential cutting, though there is no calcium here. But chronic ISR, we could have intimal hyperplasia versus some calcium within that area. Ideally, we should image now, but I think what we will do, this is exactly, I think, what was discussed earlier by Ron, that is it under expanded stent or not? In this, angiographically does not look like under expanded stent. If it is under expanded stent, then definitely you have to be very cautious with rota, because stuck burr situation happens in those kind of cases. But since there was no flow, when I took a picture, I think it's nothing wrong that we go with rotational atherectomy, then we do imaging.
And other point is, I would say the plus for rota in this case is, we want, if the unexpanded stent, rota will do a better job of expanding it. Because of the heat generation, and I'm sure part of the stents will be under expanded. We'll see it shortly. Now we are ready here.
Yeah.
And now check the speed. They are all about 150. They're all set. Good. Okay. And the advancer knob actually have the Dynaglide also now, but we are going back and forth.
Yes.
Go inside now.
So when we introduced it, we still were looking for the pedal, but now we got used to use it on the. Where is the pedal?
It is like driving the car without the gas, foot on the gas.
Yeah, we may be in the side branch. We don't know distally, but we'll see. After doing this, it's a 6 French. We are
small branch, yeah. I try to get out. You can pull back. No, what do you want to pull back?
Yeah, once we do. After, now this one will require, good.
Okay.
Same steps.
3 steps,
and yeah, and definitely you're going to get a nice ablation of the tissue.
Yeah.
So I think rota with brachytherapy is adjunct prevention of restenosis makes a lot of sense. Because if you do it with balloon, I can tell you, 10 minutes later, all the tissue falls back into the stent.
I would not put pacemaker.
And by the time you talk to the family and you say, I got a good result with balloon, the patient has restenosis.
Yeah. Instant restenosis.
Instant.
Yeah.
What we say is a patient gets restenosis by the time he's in the holding area.
That's correct, yeah.
That's it. Now, in this particular case, we haven't put a pacemaker, so we'll use the aminophylline and atropine combination. Aminophylline 5 milligram per kilogram, and 300 milligram usually, and atropine.
See, this is where the tightest the CTO starts. So just be very cautious as you're going down. You have to let the burr move forward by itself. Never try to push it. If you try to push it, that's a time. This also what can happen, why we have a stuck burr situation in ISR, because many times intimal hyperplasia is not like a calcium where you have some resistance. Intimal hyperplasia is like a glistening tissue, so burr can just slip forward through the lesion without burring, and then it gets stuck and difficult to take it out. So that's why you have to be very cautious here.
Do you
and
see a
holding
drop in the
guide.
RPM? Or I mean,
So
we don't
far
see
we are
it,
good.
We are good.
It's just about, I mean, they are also, Pablo is telling us it hasn't dropped less than 5,000.
But I would just want
Okay.
to make sure the hand on the guide in these tough situations and gradually advancing here.
So it's between 146 to 148, 149,000 RPM. So if this was not moving forward, you know, we would have gone higher speed.
Or a lower burr, smaller burr.
That's later, yeah.
Yeah.
Since it's ISR, we will go higher speed. If it was native vessel, go smaller burr.
So now,
Excellent tip.
now long segment, we need to advance so that we do the dynaglide and we advance our clocked and then forward rather than going back.
Okay, ready?
Yeah.
So hold on. Okay, good. So what I'll do is I will, you see me on my hands, I'm advancing physically.
Good.
So when we are doing that, stop. A very important point. So was on dyna, okay, this is the dyna button, you see the green button. So on dyna, you got to do brake release. So Dr. Sharma was doing brake release and then I was advancing manually forward.
And make sure the advancer knob is locked because otherwise it will go forward and then your purpose will be defeated. Good. Let's do the second part.
Samir, I could explain this later on at the end, okay?
Absolutely.
More so that people can understand how this thing is done. So we are done. So I'm just going forward with the.
Went very
Still
nicely.
resistance here, or you just
don't go
moving?
further.
No, I'm not going further because it is stent jailed. I stop here. Why did you do that?
No, but do we need to
No.
hold it there?
So not much resistance, is that correct?
Now.
No.
And the EKG
even
is very stable. The blood pressure is very stable. So these are all good
Then
signs.
we'll rewire them.
Surprised
Good.
how well that
Yeah.
guiding
No.
catheter, I had some doubts. Ron, several questions for you.
Coming out?
Yeah.
People have extended their welcome to you to CCC Live Cases. The two specific questions I picked for you so far is what is the anticoagulant and antiplatelet strategy for IVBT
So if
cases?
the patient on prasugrel, I think it's good enough. If patients coming on clopidogrel, sometimes I use Cangalor during the procedure because I concern that still they will be with the dwell time. I want to make sure that they have full anticoagulation. But if patients on prasugrel or ticagrelor, I'm fine with that. Heparin is good enough as well. Just check that the ACT is above 250. So that's pretty much the anticoagulation. But you have to remember that the catheter will dwell here more than 5 minutes because you probably need to have 2 steps. So each step is about 5 to 6 minutes. So we want to make sure with not much flow in the vessel that we don't build up a thrombus. And that's why I personally prefer Cangalor in the event that the patients are not on ticagrelor or prasugrel. But in this case, I think it's going to be okay with just heparin.
Any role of the good old-fashioned GP2B3A?
You can use it. Obviously, it's not much cheaper, and I don't like to keep something which is going to create potentially bleeding long term. The beauty about Cangalor that 4 minutes later, basically all the
turn it
cases
off.
come.
Absolutely. Finger control. Completely agree.
It's like switch on, switch off.
Absolutely. Absolutely.
Is the PDA.
Go to the PDA. Okay. So you see that here good lumen we have seen, and we are going to go to the wire to the PDA because there are multiple branches there. But the key is that PDA is the good size.
And you're still maneuvering the rotor wire, correct?
No, right now we put
No, we took the rotor wire out.
Okay.
Earlier when we were doing rota, remember the portion came out. So this is just the run-through wire. I'm just wired side by side quickly.
Okay, do a balloon first before the IVUS?
Very fast, and that's why.
You want IVUS now?
No, balloon first quickly,
okay.
And then IVUS because...
No, distally you need a different size. It's not 3.0.
3.0 is good.
You have much more
not into
control on the
PDA.
run-through than on the rotor wire.
Yeah, 3.0 will be okay.
2.5 SS.
And balloon size, you're going to use now 2.5 or 3.0?
3.0 30.
And we can do a differential pressure, knowing that the PDA is not a 3.0 vessel.
I would still not go. Then you have to stent it again.
Okay.
Let's do the proximal.
Yeah.
No, I'll do the distal. Get us a 2520 balloon.
Okay.
Go here.
Okay.
So I'm not getting into the PDA. Up to the crux,
so
we are with
fine.
30. Okay.
No, we have to have a microphone.
This is 3 or 30.
3 or 30. Okay.
Backstall.
And this is a
Yeah.
non-compliant
No,
balloon
but
or
ask them
compliant?
if they have. The non-compliant 3 or 30.
Pablo,
Yeah.
can give it to him.
Yeah.
So what I do
Okay.
with these balloons, I go to even 30 atmosphere.
Yeah,
I
20,
mean, they
yeah.
usually hold very nicely.
Yeah, 24, 26 without a problem. And then some area may still need whether short high pressure or a cutting balloon with it.
Right.
And idea is the same that you want to, you didn't proximal, yeah. Yeah. This is the area, actually we have to pull back more. This is 26 atmosphere.
And the IVUS post will tell you if you can escalate the size of the balloon, where are the area that need more pressure for under expansion. You'll get a lot of information from doing IVUS post. But I agree, before I will do the IVUS, I will dilate the PDA with a 2.5 as you're planning to do.
Good. Get a 2.520. Open the PDA and then we do the IVUS. Yeah, this is 3.0, 30 at 26 atmospheres.
So at this stage, I mean, I usually call the brachytherapy team.
He's already
Maybe
here.
Here. What is that?
Yeah, because I hate to wait for them. So
Yep.
we know
They're
already
always
that
here. We actually
Excellent.
have 4 brachytherapy cases today. So we're starting with this, and
Dr. Buxton.
Dr. Buxton is here, and he'll give us his input also. The program is running quite well here also, about 100 plus. Every year we are doing brachytherapy. Same in this area, patients are being referred for this purpose, for brachytherapy. Not too many centers, some are there, but since we were the early starter, they have a good following. So now you can see that the stent jail, this 2.520 even, is not going. So we may need a compliant balloon, knowing that not much ground support 2 or 12. Yeah?
Yeah.
Yeah. So you need
Probably
to open.
Use a compliant low profile balloon. One thing about the dose of radiation, and again, it's a question, I wonder what you guys are thinking in terms of the radiation oncologists and the physicists. But when you have multiple stents, I usually tend to give a little bit higher dose. I'd like to do it only one time, although we showed and we already have a paper that was accepted in press that repeat radiation is safe. But I don't like to do repeat radiation, so I rather do in a case like that a little bit higher dose, which is the highest dose that we are giving in situation like that, 25 gray at 2 millimeter, where I think that you guys are giving less dose. I think that we are the highest dose that we are giving in the nation. Initially, when the studies were done, the dose was 18 gray point something, 18.3. And then we did a study which was called RISC 21 when we used 21 gray. And then we went in situation like that of vein grafts when you have a large vessel or multiple stents, because remember, every stent decaying some of the beta radiation.
From there all the way.
So you don't want to see this restenosis again. That's why we give a little bit higher dose.
Right. I mean, I'm sure
We have done
some
open the osteum. Yeah.
Okay, ready?
So actually,
more
we lost
object-
that concern, that opinion from Dr. Buxton. We have been talking about this because when our circulation paper did, that was the big comment was that too thick to inhibit. Means once you have multiple layers, you're probably not exerting the same brachytherapy effect to the deep wall. And Dr. Buxton, welcome to our CCC Live. Dr. Waxman, the expert on brachytherapy, and is of making those comments that giving some extra radiation, particularly with the multi-layers. And so, yeah.
I will give it
Looking
2
much
gray
better.
more than the usual.
Can we show his face?
Yeah.
absolutely.
come here,
Let's,
Our general policy here is we have not, as you mentioned, dose escalated beyond the doses of the original Novos trial. We still use the standard 18.4 gray versus 23 gray for larger vessels. But we know that there is a dose response in radiation. That's how we do all of our cancer treatments, based on dose response. And so there is some rationale in these cases of the tissue to actually dose escalate. and your paper is one of them that shows that there is some, potential benefit for there. It's hard to quantitate exactly how much attenuation you're getting from the actual metal stents, but certainly there is some less dose there. But the actual dose cutoff is not at this point totally clear as to what's the optimal dose to use.
The question is, if there are 3 layers of stent, is it okay to give 21 or more? Okay, if we can decide irrespective of the vessel size, or what is your feeling?
With regard to a safety level, yes, you can give more. We're giving now, certainly 23 gray, you can give more than that without risk of it, and the stent protects any kind of risk, and the actual complication rate's very, very low. We use 25 gray now, single fraction, this new exciting field of using ablative radiation for unablatable VTAC. So it's certainly possible, but again, doing the studies to actually figure out where the cutoff is a little bit challenging, and these studies need to be done.
Yeah, but we're never going to get those studies.
Right.
It's hard to,
We can start IVUS.
I think that's where we call it the hard team, but now it's with the oncology and the physicists, and we get their input. And the concern initially was if the catheter is leaning on the wall, this is not a centering catheter, you may get to the wall very high doses. But surprisingly, there was no side effects of that one that we could tell. I mean, years and years and years of giving those. We've been doing it now almost 20 years. So I cannot believe it. With higher doses, and it seems that we don't see radiation effects on those vessels. So I feel that when you have multiple layers, as was mentioned here before, there is a decay of the dose, and you really want to ablate. Also, it does tell you something about the exuberant healing that you have with smooth muscle cells. So they need a higher dose to shut down.
Okay, let me do manual.
Yeah, we are going to do manual now.
From an oncologic point of view, we always tend to ignore the smooth muscle cells because cancer cells don't typically respond the same way, and muscles are so resistant to radiation that we can give them in very, very high doses, and you're obviously seeing that in practice, that they can resist the radiation doses to a very, very high extent.
No, that's true. The only time that I would refrain from doing radiation at higher dose if I have to put a fresh or newly fresh stent, because then the whole mechanism is changing. You're basically inhibiting the ability of the new stent to heal, which could promote thrombosis. But if you don't add any stent, then I think it's safe to go with radiation. But if you add another stent, that's why I would encourage you not to add another stent the very proximal RCA, even if it's not going to look that great. Because if you do that and you do radiation there is a higher
Ron,
risk.
if you know that one of the previous stents is a bare metal stent, then would you go ahead at the time of IVBT place DES or bring the patient back?
No, but in that case you do a DES first.
Yeah, right.
Yeah, we'll do a DES first and then comes back with IVBT. You saw it here. Few areas are 4 layers actually. The stent plate.
And we cannot be sure which is what.
Yeah. No, but we know that because his process started in 2003. First stent was in 2003. So that's the time when we start getting a DES cipher. Remember, cipher came in May of 2003 and then Texas in March of 2004. So he has multiple layers, and including DES, 2 DES were placed here in Mount Sinai in this RCA. But then he had things before. So clearly, at few areas, there are 4 layers of stent. But if we can if we can see it here, whatever we have, can we replay the one? Tremendous amount of still intimal hyperplasia and need more expansion. Can you replay the earlier one? Because we may need a little bigger, in my opinion, balloon.
Yeah.
Yeah, because you went with a 3.0, you definitely can take 3.5 or even 3.75 long balloon.
3.5 balloon, please, 30. Yeah.
It's good now.
Is it playing good or no?
Ron, more questions for you. Have you reached a volume cutoff that an institution is doing 20 cases a year that they should start a IVBT program, or any empirical arbitrary number?
I think 20 is a little bit stretched, but it's almost every other week, so it's not that bad.
Right.
I think it's the question of the total experience of the team. How much do they have in terms of, cumulative experience over the years? Because If they've been doing it for 5-7 years, 20 cases a year, I think it's legitimate. Right now, the numbers by the NCDR shows at least 10% cases are ISR of the PCI done in the US. I know when we talk to the Europeans, they're challenging this number, but I think this number is pretty much true if you look carefully on all your stents that you're replacing, because it doesn't have to be in the first year. We know the first year they're doing well,
okay,
but you're accumulating over 10 years period, so you probably does see a 10%. The problem, I can tell you where it is. I mean, the company, the industry,
which we can't touch,
that are running by Chris Surturhanian, they don't have enough transfer devices to give to everybody. So I think it's going to be limited, I think in the US, maybe to 30 sites and some sites in Canada, but I don't know if they'll have enough transfer device to give it to overseas.
do a PRU.
Yeah. Go a little distal.
No need.
But I can assure you, you're going to get a very good result.
Yeah.
And it's a pity not to keep that result. The brachytherapy will keep you that result.
Yeah.
And people ask me, okay, what's the likelihood that this will remain open at 1 year? So I would say at 1 year, it's usually, I can almost guarantee 90% opening. And then every year after, additional another 5 to 7% risk of restenosis. So yes, by the end of 5 years, it may restenose again. And then you can do another round of brachytherapy. We found again that repeat brachytherapy is very safe.
Remember earlier you were
Never had any thrombosis.
That you can ask the question.
Yes,
again, from a series of thousands of cases with brachytherapy, when I never added another stent, I had 0 thrombosis. So I think the issue of fearing from thrombosis is only true if you do a combination of a stent of brachytherapy. But if you don't put another stent, the whole thrombosis fear should be gone.
Yeah, absolutely agree. And actually same, everything should be done to avoid second stent. And our also, since we started the program in 2012, now over 500-600 cases, we have 0 stent in the brachytherapy area. So that is the key. Now, it sometimes happen, large vessel, you're restenose, but then there is a diagonal 90% lesion.
What size you told him? 3.5?
This is the brachytherapy system, and let me walk through the markers.
This is the brachytherapy.
The first marker is the tip of the catheter.
Yep.
It's a little bit long marker. Then you see another black marker, which is the non-radioactive seed. And then you see,
Tell them to show us now.
Traveling. And then you see
show
a
the face
proximal
also.
marker. And the proximal marker is also a non-radioactive. So in between those 2 black markers that are non-radioactive, you have a train of 60 millimeter of radioactive seeds.
Yeah.
Good. He's sending the seeds now.
Yeah.
You can start seeing now. You're ready?
Yep.
Good.
Okay, so here's the seeds. You can see again the markers that I was alluding to.
How much?
And you can see that the marker at the distal is a little bit longer than it was before, because you have, in addition to the marker on the catheter, the first non-radioactive marker, which is also radiopaque. In between, it's very hard, but if you do high resolution cine, you can sometimes see those train of seeds. And the radiation oncologist is holding the transfer device, and he give a positive pressure with some fluids, which is saline, and he makes sure that the seeds are not going to go backward. Usually they are not, but from time to time you do a burst of cine just to verify that all the seeds are in place. And right now you see that you're covering very nicely the proximal part. Your radioactive seed is outside of the stent, so you are not having any geographic miss. And distally also you can see that the radioactive marker is few millimeters, like 2 or 3, beyond that multi-layer of stent. So with one application of 60 millimeter, this is very nicely covered.
Yep. And if you need to stepping, then you need to just pull back and do that area. So only the black dot overlaps, rest should be just overlapping. The multi, like long LED, the vein graft. So you do a stepping technique. And also just want to emphasize to our viewers that those who are using bivalvular earlier back in 2000, 2003, Dr. Waxman published the paper. There were a lot of thrombosis, so we give additional heparin. This procedure was done on bivalodin, is being done on that, but for the brachytherapy purpose, we give additional IV 2000 heparin for this purpose of 5 minutes, because now there will be indwelling catheter for 5+ minutes in the vessel, and that has been associated with some thrombosis.
Show his hand.
Yeah, it's always sometimes, this is very good point. I mean, we stopped using bivalirudin at all for brachytherapy cases. I don't think we need to. As I mentioned before, sometimes we would use Cangalor if the patient is on Plavix, because we don't know if the patient responder or non-responder. So just a short Cangalor during the procedure give you also assurances that there will be no thrombosis.
Yep.
So Dr. Buckstein, what are you doing right now?
So it's a very simple system. It's just a hydraulic system. We're applying forward pressure, as Dr. Waxman said. So the system flows with forward and backward pressure from fluid. And as you mentioned, the seeds could theoretically drift back in the catheter. So we provide a little bit of forward pressure, just a very, very slight amount, so that the seeds will not, the train won't drift back approximately. And so it's a very, very simple amount of pressure. We just hold it there.
Yeah, so this hydraulic system sent the seed. We saw the seed moving into the coronary artery, and now he's holding pressure, and you see the catheter that has taken the seeds.
And when the catheter being sent, don't put your hand, don't hold it. Then you'll have a little bit of radiation.
Right.
The sometime may become 6 fingers one day. So we want to keep it only 5.
Right.
Maybe more than a little bit. Yeah, you stay away from holding the catheter.
Absolutely.
Yeah.
So, I can tell you an anecdote. When I designed the system, they said you should not use any wire because there were prior patents. So I said, okay, let's do it with hydraulic system. That's how the hydraulic system. So we did the hydraulic system because we wanted to avoid an existing patent with a wire that were more applicable to the gamma radiation. Gamma radiation was iridium-192, but that's a very high activity source. So we had to evacuate the lab, stay in the control room, and the dwell time was about 35 minutes. Can you imagine? So the beta radiation is definitely the way to do. And the other comment, I see your radiation oncologist is happy to come to the suite, to the Cardiac Cath, and that's the same with our radiation oncologists. They're actually happy to come to the cath lab. So we don't have any issue with the team. They're very supportive. We do it almost every day, but we let them in the morning to know that there will be a brachy case, and then the team assemble, they're coming. It's really a seamless when you have the cooperation of the team, which is very, very important.
Well, and actually, that's a very important point, because you require, many times you see patients in the office, you book for brachytherapy, and the schedule, what we have set is Tuesdays and Fridays. In the morning, we have 2 to 3 cases. If for some reason, our radiation oncology team is not available, we write it on our calendar. So once we are scheduling the case, it will be written that IVBT not available for that purpose. But by and large, Tuesdays and Fridays, between 2 to 4 cases every week we are performing now. And as also avoiding the stenting at all in these cases. That should be the goal. Even if you don't have excellent results, you have a moderate lesion in the proximal RCA, like in this particular case, will not have a perfect result in the proximal RCA because there is no stent there. But that's okay. Don't do anything stent at this time, and maybe in the future.
Somewhat related to this, Samin, is a question by Dr.
Time for the seed to come back.
Okay, let's see now that?
Yeah.
Row.
Okay.
And you see the seeds are traveled back already.
Yeah.
Good.
See how they're traveling back, and now the catheter traveled back. So that's good. I mean, that's really a very nice, slick procedure. So if you ask me, how did the seeds know to go back? There is actually, this is an like a loop catheter. So by changing the direction of the fluids, the radiation oncologist can control to send or to retrieve the seed. They're just moving a lever, and then the seeds travel the other direction.
Anu, a question for you.
Usually after this procedure, I give a little bit nitro or nicardipine because often when you have the radiation catheter for 5 minutes, you have a situation where you're going to have some spasm.
Ron, the more I think about it, really, the attributes of Cangrelor are beautifully suited for such procedures. Have you had the chance to write about it?
No, we have not written.
Maybe a
because we have
letter,
not put lot
to,
of-
yeah.
But I think, yeah, we're not going to do a randomized study there. But I think I use more and more Kangalor in my experience because I think I like the switch on, switch off. Many times, patients may go to surgery for hybrid. It's actually a very useful drug.
Just submitted a publication with 50 consecutive STEMI cases. Anu, a question for you that this is from Dr. Ritu Bhatia. Any questions on the PLV branch which seems to be diseased?
So
I know PLV branch we have seen. So I think the PDA is a patent. PLV branch was small. It was collateralized. We can see from the left system. For this time, we are going to leave it alone since there's a good collateral. Our focus was PDA. You see, our wire went to 2 branches. So that is always the case. Your total occlusion and your 2 branches always focus to getting PDA back rather than the PLV branches, which actually is very small. If you see here.
And look at the IVUS now. The stent has really nicely expanded.
Very nice. Yeah, you had a very good outcome.
But 1, 2, 3, 4 layers there. 1, 2, 3, 4.
No.
And even if you see some tissue prolapse, don't worry. The tissue will be apoptosed over time.
Look at this.
So when you take this patient 3 months to a control follow-up, you're not going to see that tissue. You're actually seeing like an angio mark that the tissue that was there at the time of the procedure was eliminated.
You have some question for Dr.
Very
Buxton,
nice outcome in this view. The last thing that I'm interested in is knowing the distal flow, because if you have a good distal bed, the prognosis of this case is much better than if you have a very small branches that are occluded. You need a good flow, as we say, good inflow and good outflow.
Ron, how does the economics of these cases work?
Do we have any questions or we let him go?
So there is a code for IVBT, actually very nice reimbursement.
I was thinking.
And also the radiation team can bill for that. So it's actually pretty lucrative. And again, I think that in the old days, brachytherapy came and then Cypher came. And Cypher came, it was about $3,000 reimbursement. Then it was shrink over the years. Brachytherapy was about the same, but never shrunk because the volume was not that high.
Right.
So it's still a good brachytherapy reimbursement code.
Okay, so we can just hear the last word from Dr. Buxton, and then he'll go on to do another IVBT. Dr. Buxton, tell us our program. We restarted together.
Yeah,
now it's the 8th year now.
So the program here has been very, very successful. As Dr. Sharma said, we're doing sometimes anywhere from 4 to 6 cases a week at times. And like I said, the team works very, very well. Just having established days, to do the procedure works very, very well for everybody because we have the things. And then we make accommodation. If they have a certain case or emergency, we have to do a different day, then we do that. As long as everyone knows, then we're very happy. Our physics staff is happy. We're happy that it works very well for everybody. As I mentioned before, there are codes on both sides. So financially, it works well for both departments.
Okay. All right. Very good.
They like mentioned, I think they're always available. So, he also is, sometimes we add on, he comes here immediately. Yeah.
Right.
Good.
Very well. Thank you.
All right, thank you. So we get ready for other case. Okay. So now with that note, you saw the angiogram. You want to take a picture without the wire and and then I go with my presentation.
Okay.
And
good.
we know
take
that.
A picture.
Yeah. You want to give some medicines or no?
We gave.
Okay. Good.
Ron, you are happy with the results?
Let me
He
take
did
that
say
final
all depends on the distal vessel. PDA is nice and good.
Yeah. And the moderate disease of the proximal, that's okay. As we said, we are not going to put a stent. There's no stent there. And this case is, and then remember, this is not the last procedure for this patient. He'll come back with so many. So see the stent, the architecture of all the vessels, nicely stented is very clear. And luckily, look at this guy. 10 plus 9, between 8 and 10 interventions, no normal ejection fraction. Every vessel has been stented, and then same thing. Now, this is the first time he presented with a CTO. Every time has been a disease, but this is the first time he presented with a CTO and with the good results of the brachytherapy and so.
I think the ISR was very well treated. Because it was CTO, you expect the vessels to open to be more reactive over a short time. You don't have to run after every side branch. So I think that's the best that you can get. It's a very nice demonstration for the utilization of brachytherapy for really a very difficult ISR case.
And I really thank Ran. I know that we drafted you in very late, or we say very early yesterday morning, and so thankful that you could be. I'll continue my presentation as usual, but we ask you to for 8 to 9, and I know you have other commitment. We will be happy to relieve you because of, but more importantly, thank you very much for always to be a great supporter of our CCC Live in person and today with the Zoom.
Thank you very much for the opportunity. They indeed already called me from the lab, but I'm always like the collaboration that we have with you, Samin and Anu and the rest of the team at Sinai. I feel like we have a special relationship between the MedStar and the Sinai group.
Yes.
So congratulations on a great case. Samir, Dr. Mehta, thank you very much for helping and moderating and be part of this great program, and look forward to see you in the near future in person.
Good.
Absolutely.
Thank you.
Thanks, Ron.
Okay, we can go to the our slide presentations, and this is our staff, cath lab staff. As you can see, a lot of things are done while case being happening. Patient blood pressure goes down. They give automatic, our nurses give automatic neosynephrine, 100, 200 microgram, which is 0.1, 0.2 milligram, keep blood pressure more than 100. Pulse rate, systolic pressure more than 100. Pulse rate goes down, atropine, and aminoflin if there is no pacemaker. So all this is inbuilt in the regular cath lab protocol, and we are so thankful to our staff getting to a level where we are, that's seamless when we are doing these complex cases, that we are concentrating on our in actual procedural work. With that note, I know we went a little extra time, but they still have to go through our regular presentation. That is 2 points. One is the TCT Connect 2020 stent trials. We did show some trials last month, and these will be the trials of high bleeding risk patients, Cobra Reduce, Optimize IDE, and Host Reduce Polytech ACS trial. And the focus review of the month will be trends and outcome of ISR in USA. Some of them which we already spoken, including what Dr. Waxman discussed. So basically, we know that patients who are high bleeding risk, you do a dual antiplatelet therapy, they bleed more. And what are the criteria of the high bleeding risk? Most often it is the age and patient on chronic oral anticoagulation. And then of course creatinine, anemia, hematological disorder, major bleeding, and history of stroke. The Xience, as you remember, 90 and 28. If you see, majority of your risk factors are age and anticoagulation. So those are the two most important our bleeding criteria. And this is actually we from the Mount Sinai Interventional Database with Dr. Roxana Maran and our fellow David Cow and Dr. Keeney, the senior author. We published this in JAC, Validation of the Academic Research Consortium High Bleeding Risk Definition in Contemporary PCI Patient. People did ask us a few months ago that can you measure this? Can you measure prospectively various criteria in the real life setting, not in the trial? And this is where put it as a major and minor criteria. You can see many patients have more than 1, 2, 3, and 4 high bleeding risk criteria, and those are same: age, anticoagulation, and so. And then the bleeding endpoints. So patients who have bleeding risk criteria, they bleed more. So we have the data 3 times more in 1 year. If you're non-high bleeding risk group, 3.2 becomes 9, and also these are associated with all-cause mortality and myocardial infarction. So bleeding is bad, and multiple factors can happen. Then we have so many trials which have been done, single-arm trials with the Leaders Free 2, Evolve Synergy, DAP, Model U SCS, Onyx 1, Xience 2890, all were the single-arm trial with the control, basically the historical control. There are 2 randomized trial ongoing in the high bleeding risk patients, which is compare, and Biflow DAPT will know it in the next 1 to 2 years, comparing 2 different types of stent. Now, this actually very nice editorial of our paper, and that is that the safety of PCI, patient undergoing, is clear, that the ARC HBR criteria are practical and actionable, not just academic. So clearly that you can incorporate in the practice, and they translate into a worse outcome. So everything should be done to reduce the bleeding of the various strategy, limiting your antiplatelet therapy, DAP duration, and so. Major trial, which was just presented few days ago. I'll talk next in my next month's presentation. This is the first time trial of abbreviating the DAP to 1 month in all comers, both high bleeding risk as well as non-high bleeding risk patients, and we'll talk about it next month. Now let's go to quickly some 3 other trials. Cobra Reduce, this is basically a special, the nano-coated coronary stent, no drug. And it's a special cobalt chromium alloy, supposed to be anti-thrombogenic. They do put a polymer on it, and basically said that what if by using this Cobra Reduce, patients who require triple antiplatelet therapy, triple therapy, because those who have indication for AFib and so should you give DAPT only for 2 weeks or longer? This is our standard for 3 to 6 months, which was left to a study done from Germany. So what happened is, in the device arm, the DAPT was given clopidogrel for 2 weeks, and after that none. And then other group continue, and then OAC, oral anticoagulation, and aspirin continued subsequently. Now in the control group, you see the clopidogrel was given up to 90 days, maybe up to 1 year, and then after that only 2 agents, oral anticoagulation and aspirin. I know many people will say, we don't use aspirin when we use anticoagulation. That's a separate story, but this trial, they did use aspirin. So what did they find? As you can see, the Cobra plus 14-day DAPT versus DES with 3 to 6 months DAPT. In these patients, it showed that overall, the bleeding was slightly lower with the 14 days DAPT, which is clear-cut, but non-significant, 7.5 versus 8.9. Now, once you go to the death, MI stent, thrombosis, ischemic stroke, that is what we are worried about by shortening the DAPT duration. See what happened. Clearly, it is against the Cobra short DAPT protocol, 7.7% event versus 5.2. And this actually leads to overall the conclusion that this Cobra for short DAPT was inferior to your DES and standard DAPT therapy. And of course, the bleeding was slightly lower, but overall failed. Overall, the trial was negative. Second was the optimized IDE trial, which is a very important. What if, like probe, you remember we used to have ACE balloon. What if you put a stent on the balloon, no wire? So direct stenting on the fixed wire using sirolimus eluting stent, and compared to your regular and the drug-eluting stent. And this is basically what the trial calls, it's a slender integrated delivery system. In this trial with a transradial in optimized IDE, patients were randomized to this stent called Swellet, DES versus control DES, and with a primary endpoint, as you can see here, inferiority margin was 3.8. Reached to while it was supposed to be 3.58. So overall, trial failed. Event rate was 10 point, target was lesion failure 10.3 in the Swellet versus Xience or Promus was 9.5 with the individual endpoints here. So numerically lower event rate in your regular DES compared to this new innovative Swellet DES. So basically it was non-inferior, and a lot of patients did have a troponin positive. Then one of the major trial which was presented is the current generation drug, our durable polymer versus biodegradable polymer. This is a trial from Korea in large number of patients with acute coronary syndrome, and whole purpose was that is one strategy better than other. But because many times there was some data in the past that maybe the biodegradable polymers are better. This is a 3,500 patient acute coronary syndrome patient. As you can see, various kinds of durable polymer used, Promus, Resolute, Xience, and Design, and of course the biodegradable polymer with Ultramaster or Zero, Biometrics, Nobori, Synergy, Biometrics, and what they found basically the groups were comparable in majority, but you see here biodegradable polymer had an event rate of 6.4 and durable polymer has 5.2 and lost their inferiority margin, and these are the individual endpoint. Patient oriented and device oriented events occurred lower in the durable polymer group versus biodegradable. Even stent thrombosis was 0.1 in the durable versus 0.4, and of course TLR 1 versus 1.8. So clearly durable polymer wins in this issue. So the second point is our focus review of the month, trends and outcome of ISR in USA. So this is the data from a large number of patients from United States, ACC, NCDR with a 5 million patients, and they found the patients who had ISR intervention and non-ISR intervention. So this is basically 500,000 ISR, 10% intervention we do with the ISR for the ISR and remaining 90% non-ISR, and these over last, you can see it is 7-8 years, our overall intervention of the ISR has not changed. So somebody says the drug-eluting stent has changed. The 6 ISR DES is 6%. You see, maybe it was 5.8, now it is 6. So clearly, the overall has not changed. What has changed is the BMS ISR, which has gone down. Second point, basically, if you see that, of course, we use more patients with the DES, they have more complexities, and so compared to bare metal. Second very important point was how these people present. As you can see, when ISR is presented, 52% of the time it's unstable angina, 19% of the time it's non-STEMI. And that kind of has remained, unstable angina remain, presentation is constant, non-STEMI actually have gone a little higher, and patient with the non-ACS has gone down to about 15% and STEMI around 9. So presentation of the DES ISR has not changed over time period. You can see here, maybe slightly uptick in the non-STEMI. This actually boils down to that almost 25% of patients, when they present with ISR, they present with the MI, non-STEMI and STEMI, and of course with a non-ISR, large number of patients are STEMI and non-STEMI. But more important is, restenosis is not benign. Many times these patients present with a non-STEMI and STEMI in 1/4 of cases. Very important information we also learned, that when the ISR comes, we always tell patients that, you know what, if you pass 1 year, you are good enough. No longer true. You see that 1 year, only 30% of cases have developed the restenosis. Your 1 to 2 year, another 20%. But more than 2 years is 50% almost. So we had to tell the patient that once you do a DES particularly, although same to BMS, the restenosis process is not 1 year or 2 year. It could be longer. Very important issue. Now also when we treat these patients, and this is very important point which I briefly earlier said, when you treat ISR PCI, majority of the time you just do a PTCA or 17% atherectomy. But if you do a non-ISR PCI, majority you put a stent, 96%, and atherectomy is in 4.5%, and brachytherapy is only used for ISR PCI. So if you're non-ISR PCI, you do not use the brachytherapy as shown here. So this is the overall treatment strategy, and the more important, on the right side, the brachytherapy numbers are going up, and I'm sure we are still less than 1%. With the Washington Hospital Center and Mount Sinai, probably contribute half of this number. So these, now what are the outcomes of the ISR PCI and non-ISR PCI? Seems to be identical. Little lower length of stay, but seems to be overall identical between two strategy. So not benign. So very nice editorial, the conclusion that ISR represent approximately 10% of all PCI and treated most commonly with another stent. Approximately 25% of patients present with acute MI. In-hospital outcome of patients with ISR PCI are comparable with those undergoing non-ISR PCI. So we put it together. This is a nice editorial by Castrati. These are the data from Germany center. That first intervention 8%, second time 17%, kind of multiple of 8 and 10. So third became 23%. So clearly that we need to enrich our treatment armamentarium of these cases. Question is how? Do you do a drug-coated balloon, which we don't have it here? IVBT should be more, maybe imaging guided PCI. And so just to sum it up, we put it in a simple way. The durable polymer DES better than biodegradable. Nano-coated stent without drug-eluting and short DAPT is inferior to DES. Fixed wire direct stenting inferior to DES, and abbreviated DAPT with durable or biodegradable polymer is encouraging in high bleeding this patient. The second, the recent NCDR registry data reported 10% incidence of overall ISR and 25% present with MI, and outcomes are similar, but key is that newer PCI strategy to treat ISR are needed to improve the long-term outcome of these patients, like IVBT, drug-coated balloon, imaging-guided PCI, some data, and maybe some kind of nanotechnology. You infuse the drug into the vessel after the intervention. They are being done at present. So quickly, 3 questions before Dr. Keeney gets to calcificate that following statements are true regarding the recent randomized control trial of durable polymer versus biodegradable, except lesion-oriented outcomes favored durable polymer. Death and MI incidents were similar between two groups. TLR trended to be lower with the durable polymer. Stent thrombosis numerically higher in the durable polymer DES group, and patients-oriented adverse outcome were numerically lower with durable polymer DES. Answer is D, because stent thrombosis is numerically lower in the drug durable polymer 0.1 versus 0.3%. Second, following are the stent trials in the high bleeding risk patients except Xience 2890, Optimize IDE, Onyx 1, Evolve S, Leaders Free. Clearly, Optimize IDE was the new stent design. The last is the following are the true statement regarding the trends and outcome of ISR in USA except ISR PCI makes about 10% of the total PCI volume. ISR commonly presents with unstable angina and MI. ISR most commonly presents with less than 1 year of baseline PCI. Outcome of ISR PCI is similar to non-ISR PCI, and atherectomy is more commonly used in ISR PCI versus non-ISR PCI. Clearly, we saw that answer is C is wrong because majority of the ISR present after 1 year, like almost 20% within 1 to 2 years and 50% after 2 years. With that note, we get to the very important addition to our more explanation and teaching by Dr. Keeney on this cardiologyapps.com and with the calcificate.
Yeah, so every time I think we can highlight the apps, how this digital teaching is going to be the new platform for most people around the world. So in Calcificate, today's whatever we've seen today, discussed today, everything is part of that. So if you go to Calcificate and then go to the next, so if you see there's 6 boxes and you see the undilatable lesion, press next. Yeah, so this is where it is. So you choose which you can choose undilatable lesion, and in undilatable lesion we have put intracoronary stent restenosis, which is exactly what we saw today. And then you can say that did you want to base on angiography or intracoronary imaging, and one of the two, whatever your decision, in the sense angiographically that you know that there are 2 layers of stent, or you do imaging, and when you image like we showed today, if you see 2 layers of stent or 1 layer of stent. I think this was already discussed. 1 layer of stent, ISR, consider 2nd layer of stent. But if there are 2 layers of stent, what is the next step you do? Then you decide by the imaging finding that was it diffuse or underexpanded stent, intimal hyperplasia, or how bad the intimal hyperplasia is, or diffuse or focal. Because if you have underexpanded stent, like we discussed today, just go with high pressure balloon, dilate and come out. Actually, no need to even put a 2nd layer of stent. If it is just intimal hyperplasia and focal, you can do just atherectomy, cutting balloon. So it just takes you step by step which pathway you need to take. I cannot show every pathway because you need to press the button what you see in each case. So today we saw intimal hyperplasia, diffuse, and then we picked atherectomy. Also, you see on the top, you can decide if today we were able to get the rotational atherectomy wire all the way down. If the wire, we cannot get a rotational atherectomy wire, we already discussed today in the case that you already have crossed with the CTO wire and you can use laser in instant restenosis to just do atherectomy. And then, of course, what we showed today is that if you have access to brachytherapy, you do brachytherapy, and this treatment modality based on the app keeps changing when we have drug coated balloon. So this is and also these are all the other apps. So I think every time we will highlight what the apps are showing and how you can use this platform to for quick education and management of patients. They are depending on various lesion morphology that you see in the cath lab every day.
All right, so we are done here.
Anu, outstanding. Yeah, there was one very nice little tip which I picked up in one of Anu's last slides on the app, that for these IVBT cases, take a final low magnification angiogram to look for any edge dissection, a point which I think it's worth mentioning. Anu, final words from you. I think you do get a appropriate title for interventional cardiologist app queen.
Yep.
Thank you.
Yeah.
No,
okay.
I think that's the future for us, is using the platform, digital platform. I think I did mention to you at the end of the case, I want to show you how you manage this rotational atherectomy, which many people remember. Right now, Rota came years ago when we were training, and we got so proficient in doing rotational atherectomy. Subsequently, OA came, which was still steps, but way easier. And that is why, when first OA came, we were also finding it very hard that we are just using the finger and not using the foot. You're driving a car without using a gas. Can you see?
Yeah.
You can see. You can using a gas. So, but I can tell you, the old technique is probably here to live. But now, after TCT, IVF has come out, and I think everybody believes that probably will be way easier than these two technologies to take care of calcific lesion. Today, we did rotational atherectomy right from the proximal RCA all the way to the distal RCA. So if you see there, what rotational atherectomy allows here is 9 centimeter, 90 millimeters. That's all the way from here to here. If people can see.
Yes. See it very clearly. Yeah.
And then what happens is the whole process, which I always teach, is when we are doing rotational atherectomy, the 3 steps to remove the tension. The tension is the wire, which is a rota wire in the center. Then this is a Teflon sheath. Can you see? Oh.
This way,
Yeah, this is much better. No, Anu, this is fine
Horizontal.
because the
Okay.
top
This is the
camera
camera.
from the ceiling is picking it up.
Okay.
Yeah.
Okay, so this is where it is. So I thought, okay, camera. So this is the wire. This is the Teflon sheath. And no, this is the burr. So the wire, the burr, and then this is the Teflon sheath. So there are 3 layers. There's a friction always. And the way the system was made, you have the rota wire. The rota wire comes out here.
Yep.
You see here. And then once it comes out, it has to be locked. So this mechanism is to hold the rota wire in place. The 360 centimeter of the wire is held in place by this lock mechanism. It has to stay in place tight. And then what happens is the rota with the Teflon sheath moves over it. Okay, that is how the burring happens. And why we have the DynaGlide? DynaGlide, the rotational atherectomy is about 70,000 RPM with very slow speed. So what we do when we do 3 steps, you see here, you move this back forth. So any tension between the Teflon sheath and the burr is removed. Then what you do is you go forward, and when you're at the Y connector, anything between the burr and the wire is removed. So Teflon sheath and the burr, then the tension between the burr and the wire, and the last step is you press DynaGlide. So this is the explanation why all the tension between these 3 have to go away. The next step, how do you move the burr forward, which is very important. You do your rotational atherectomy where you will go forward slowly, and then you have hit your 9 centimeter. You still have to go to distal RCA like we showed here, we could not reach. So you cannot do anything, you've done your burring. So you see that also when you do that, if you can see here, the burr which was here, if you see here, you can see it?
Yeah.
Yes.
Yep.
Good. So as you move forward, that's it. We are done. We have hit the end of the road. So how do you get the burr back? You have to go to the mid RCA as well as so that you'll go to the distal RCA. So what you do is you come all the way back. Now what you do is you move this, you have the wire, so you move this manually forward. To do that, it will not happen because this wire is already held by this brake. So there is a tension. You need to do brake release. You see this button? So that's what Dr. Sharma was doing. We press the Dyna button. Why this is not working now? Huh?
They're not connected, but you press the Dyna button. Yeah, that's fine.
Okay, press the connect so that they can see it. When you press the Dyna button, and why Dyna is important is because when you're moving forward, you want to move with only 70,000 RPM, not the full 150,000 RPM. You're good? Okay. So your Dyna button is on. Then what he did was, he was brake release. So when he's doing brake release, what happens is the wire is released. So the tightness between the friction that is between the wire, the burr and the Teflon sheath is all released, and then he did the brake release. Now the burr is free to move, and what I did is I manually on the dyna, okay, hold it. Why this is not staying? It should be staying that.
Yeah.
Not staying. Okay, hold it.
Yeah.
Then you can manually move forward on the wire.
We're not the wire right now. Yeah, that's fine.
Maybe the system problem.
Yeah.
So that is how you moved from the proximal RCA to the mid RCA. Then once you're in the mid RCA, now you have the length back. Then you can start using and do the burr.
So basically stepping up and make sure you pull back and you tight it. Otherwise, when you are advanced, it will go further. Yeah. So that is the key. But yes, long segment, more than 100, 110, 80, you can very well easily do it, 80, 90. But additional, you just stepping it, just like we showed you do for brachytherapy.
Yeah, distal RCA and even many times PDA, you need this steps.
Okay, hopefully it's very clear.
Very
we went
useful
to multiple
tips,
steps.
Anu, yes.
Good.
And congratulations again, Samin. Excellent coordination with the brachytherapy team. We are grateful for Dr. Waxman, and we conclude today's session. And session number 138 will be on December the 15th. Stay safe, and hopefully the vaccine will be on its way soon.
Yeah. Moderna or Pfizer. Yeah. All right.